Great, thank you. Well, good afternoon, everyone, and thank you for joining me today on this sunny afternoon to talk about aging and bleeding disorders and some complications and considerations to think about. My name is Pamela Jarrell, and I am the RN Program Coordinator at the Levine Cancer Institute, HTC of Levine Cancer Institute, and Levine Children's. All right, just a few disclaimers. I am not an aging expert. I am a nurse, and I'm aging too. So we're all in this together. So don't let aging get you down because it's just too hard to get back up. All right. So we'll talk about several things today. We'll talk about life expectancy for our bleeding disorders patients and a multitude of health conditions. All right. So today in the general population, the age expectancy for males is 77.8 years and 80.5 years for females. So how does our bleeding disorders population compare to that? For males with hemophilia A and B, mild to moderate disease and HIV negative, the life expectancy is 75 years. With males with hemophilia A and B, severe disease and HIV negative, it's 63 years. And for males with hemophilia A and B, regardless of severity and HIV positive on heart therapy, 38% of that population is living at least 20 years after diagnosis of HIV. So as you can see, all of our statistics so far focus on hemophilia. And most of the information we will discuss today is based on data from men with hemophilia because that's where the research has been for many years. However,
how you ladies doing today?
However, we can reasonably assume
right here, let me get
that's what's good for the goose is good for the gander,
Good.
and that women with hemophilia and men and women with von Willebrand disease will experience aging and have similar complications and considerations as we get older. But the good news is that the focus on men with hemophilia is changing to include more research on women with hemophilia and men and women with von Willebrand disease. As Dr. Paula James and Dr. Angela Wayand recently wrote in an article titled Sexism and the Management of Bleeding Disorders, that sexism is a long-standing issue in bleeding disorders leading to inequality for affected women. Clinical and research focus has been on men and hemophilia, and women with bleeding disorders have been under-recognized, under-diagnosed, and undertreated. And honestly, we are just beginning to scratch the surface on what we know about bleeding disorders and aging. So during our discussion, please feel free to take yourself off mute and ask questions. I'd like this to be as interactive as possible. So back to our life expectancy. Because we're living longer, what did that look like in the past? Well, in the past, life expectancy for men with hemophilia was 11 years of age in the early 20th century. So we have come a long way. In the 1970s, the life expectancy increased from 55 years to 63 years. But in 1987 to 1990, we had a downturn to 40.5 years. So as the bleeding disorders population is getting older, not only are the typical aging issues encountered, but health issues do become more complicated when you add the diagnosis of a bleeding disorder. So what about this downturn that we had in the 80s, late 80s, early 90s? That was a result of the HIV and hepatitis C infections that were by no fault of your own due to contaminated blood products. So that's where that downturn to 40.5 years came into play. So what's changed to increase life expectancy for our bleeding disorders patients? A lot has changed, actually. So in the 1970s, factor concentrates became available, so prophylactic treatment was available. In 1975, the first federally funded Hemophilia Treatment Center opened in the United States. And the benefits of a Hemophilia Treatment Center is earlier diagnosis, earlier initiation of prophylaxis therapy, and comprehensive treatment. And in a landmark study by Dr. Suchi, patients with hemophilia who received care at HTCs had a significantly decreased risk of death. And quoting from the article, mortality rates in hemophilia are 40% lower in patients who use HTCs than those who do not, despite the fact that the more severely affected patients are the ones typically visiting these centers. So a lot has changed in the past 50 years.
Pamela, where was that first HTC?
The first HTC, that's a good question. I don't know the answer to that, but I will try to find that out. All right. In 1985, the American Red Cross began screening blood for HIV. In 1982, they began screening blood for hepatitis C. In 1996, heart therapy became available for HIV. And in the early 90s, treatments for hepatitis C became available. The first treatments were very difficult to tolerate, but now, since 2014, with Harvoni coming to the market, that was a real game changer, very easily tolerated and highly effective as the first curative cure for hepatitis C. So as you can see, things have changed a lot, but today's reminder is overall, aging affects the bleeding disorders community in much the same way as the general population. So we're not getting older, we're just getting awesome. So let's talk about heart disease. So you have to take care of your heart. And if you were in the physical therapy or the nutrition section, I'm sure you heard about eating well and exercising. So young at heart, but slightly older in other places. And heart disease affects the larger general population in the United States, and there is a high risk in this country, and it does increase with age for all of us. But what are some things specific to our bleeding disorders populations? Well, it's possible because you have a natural blood thinner that you have less risk of clotting events, such as those that would be related to atrial fibrillation or Afib. So Afib is an abnormal heart rhythm where the two top chambers of the heart, either the right or the left, they quiver. And while they're quivering, the blood is sitting there and it can clot. And then when the heart does contract, then those clots can be sent out into the circulatory system. So because you have a factor deficiency, you're not as prone to clotting. So there's possibility that you may get a pass on that one. But there is an equal risk of heart attack. There is an equal risk for blood vessel blockages, but there does seem to be a higher risk for high blood pressure, 50% in the bleeding disorders community compared to 40% of the general population. And more commonly seen in our hemophilia males with mild disease. And we don't really know why we see more high blood pressure. And it's important to know that most of the research is research looking back at hospital discharges and also information that we input into the Afib data set. So still more research we need to do on that topic. So continuing with heart disease, there are things we have to start to consider. The mainstay of cardiovascular prevention therapy has been aspirin, which is an antiplatelet therapy. But we know because it inhibits your platelets, we don't recommend that you take that. but it may become necessary for you to take aspirin, and then that is something we would need to consider of how to support you with factor. Anticoagulation therapy. Those are the products that interfere with your clotting factors, and the most common ones are Coumadin, heparin, Lovenox, and then the DOACs, which are the oral anticoagulants such as Eliquis and Xarelto. So if we add a medication that decreases yet another clotting factor, what does that mean? Sounds kind of messy, right? Well, it can be pretty messy. When we start talking about surgeries and procedures, such as bypass surgery, heart catheterization, ablation, and valve replacements. So let's take a look at a real life example. We have a 70-year-old man with mild hemophilia A. He has had continuous atrial fibrillation for 6 months. Cardiology is recommending ablation with a possible Watchman implant. And per cardiology guidelines, patients are to receive anticoagulation therapy for at least 3 months post-ablation. Makes my antennas wiggle. So the question is, what do you do? You know, we can't say, oh, they have a bleeding disorder, they're not going to clot, and cardiology is going to say, yeah, but we have to follow our guidelines, and you can't guarantee that. So what do we do? So the plan is that in that 3-month post-ablation period, the patient will receive long-acting factor every other day in order to achieve a factor level to support the anticoagulation therapy. So we have to have both things happening. We have to, keep the blood from clotting, but also keep the patient from bleeding. So it becomes a very delicate balance. So even with an extended, a long acting factor, that every other day infusion, that's taxing. That's taxing on the patient. It's a lot of exposure to factor and a lot of inconvenience for the patient who doesn't self-infuse to go back and forth to the infusion center every other day, or to have home health come to their home every other day. All right, let's talk about liver disease. So the two main concerns in our bleeding disorders population would be HIV and hepatitis C. So in HIV, there is an associated risk with increased atherosclerosis, which is the buildup of fats, cholesterol, and other substances in or on the artery wall. But we do know that our HIV patients are living 20 years plus past their diagnosis. And the heart therapy that we have for HIV now has made HIV not a death sentence, but a chronic disease. So our patients are living longer with heart therapy. With hepatitis C, are men with hemophilia who were born before 1975. Between 85 to 93% of them have been diagnosed with hepatitis C. But the response rate to the therapies that we now have show upward to 80 to 90% efficacy to eradicate the virus from your system. So it's important to note that, we know that the HIV and hepatitis C issues became a problem for our patients because of the contaminated blood products. And in our clinic, we are always very, very cognizant of documenting that the HIV and hepatitis C experienced by our bleeding disorders patients was due to contaminated blood products. So if HIV and hepatitis C are now chronic diseases and hepatitis C can be eradicated, why do we worry about these diseases in our aging population? Well, we worry about the lingering effects of treatment that was delayed or under treatment of either disease. So, should we encounter a situation of advanced, undertreated, or untreated viral disease, we could down the road be looking at procedures such as liver biopsies, looking for fibrosis, for cancer, for cirrhosis, other liver diseases. And when you are doing an invasive procedure on the liver, there are high levels of factor concentrate needed before or after because the liver is very prone to bleeding. But it may lead us down the road to look at more non-invasive assessments rather than an invasive biopsy. And then, the worst case scenario would be a liver transplant. And that again would present some intensive complications, both surgically and post-operatively, but it is curative for hemophilia. Who can tell me why a liver transplant would be considered curative for hemophilia? Anybody have a guess?
Coagulants begin and establish themselves within the liver.
I'm
Isn't
sorry,
it?
can you say that again?
Doesn't the coagulants begin and nurture within the liver originally?
They do. That's right. Your factor 8 and factor 9 are made in the liver. So if you get a new liver, you get factor 8 and factor 9. Genetically, you still have the mutation. And we don't know how long that cure lasts. I guess it depends on how long the liver lasts, but it's kind of an interesting thing to think about. All right, moving on. Thank you for that answer, by the way. I appreciate your input. So when we talk about hepatitis C, there is some increased risk of associated liver cancer and perhaps HIV-associated non-Hodgkin's lymphoma. We do not have good quality data on how much of an increased risk there is for HIV and hepatitis C for our bleeding disorders community, but as we age, we will learn more. All right, so just another today's reminder. Overall, the aging population, the aging in bleeding disorders is similar to that of the general population. Don't want you to get too caught up in all of us getting old. All right, so dental issues. Well, I hope that everyone can looks in the mirror and sees healthy gums, but we know that sometimes we end up with dental disease. There's no indication that periodontal issues are increased in patients with hemophilia or von Willebrand, yet we know it is associated with aging, so it is something that we have to look at. Things to consider would be dental extractions, dentures, either initial or replacement, dental implants, and then medication that cause xerostomia, which is dry mouth. And that can lead to bleeding gums and oral mucosa, dry and cracked lips, and you can imagine. So that xerostomia can also often be a result of medications. So medications for high blood pressure, medications for depression, pain medication, tranquilizers, diuretics, and antihistamines. But there are non-prescription treatments that we can use for dry mouth. There are products, over-the-counter products that you can use, talking to your doctor about switching to a different medication for a condition to see if you have the same result and less dry mouth. So let's talk about our muscles and bones. And this is what we usually talk about with our bleeding disorders patients. We usually have a high focus on the muscles and the bones. And you know you're getting old when you stoop to tie your shoelaces and wonder, what else can I do while I'm down here? All right. We're all familiar with hemarthrosis, which is bleeding into the joint, and that leads to hemophilic arthropathy. In severe hemophilia A, patients 65 or older have arthropathy, and one or more of the joints most commonly affected by hemarthrosis, which would be your knees, your ankles, or elbows. There is, the research shows an increased risk for osteoporosis or thinning bones. And hemophilia has been associated with what we call low bone mineral density. And about 2/3 of the patients with moderate or severe hemophilia older than 50 have some osteoporosis. So that's why in your comprehensive visits, we're checking your vitamin D levels and talking about calcium. Complications and considerations. We begin to worry about pain management because as the body ages, medications are processed differently. And we know that there are limitations on the medications that we can use. And then just pain itself, is it chronic arthritis or is it an acute bleed? And sometimes it's hard to tell the difference between the two. Something that Jennifer talked about in the physical therapy section was point of care ultrasound, to be able to ultrasound that joint, look and say, does it look like there's a bleed in there or does it look like it's the arthropathy? But there are some limitations varying among clinics due to the cost of the equipment and the investment in training someone to operate that correctly. The other thing we worry about is synovitis, which is the inflammation of that synovium. So the synovitis and the hemarthrosis, this picture was shared also in the physical therapy section, leads to bone growth, bone overgrowth that you can see here. And that can result in reduced range of motion. And as we can also see some limb length discrepancy. We may see a leg that's longer than the other or an arm that's longer than the other. So some complications to think about would be the pain, the reduced range of motion, and the limb length discrepancy that all lead to a concern for falls. So the annual fall rate among people with hemophilia over 65 is about 30% and increases to 50% for those over the age of 80. 10% of those annual falls result in serious injury. So things to consider as we age is balance training, things like Tai Chi and yoga, so that as we age and those bone issues come into, have been there for a while, that we have good balance training to prevent those falls and serious injury. Other things we would consider and look at would be joint replacements, which are going to require high doses and increased duration of factor concentrate. And we actually can create a situation where we cause a blood clot. If you are in a facility that does not have real-time factor level testing, by the time the test comes back and we find out that we have your factor level at 400%, that's just a number I'm pulling out of my hat, we can actually cause a blood clot. So we need to make sure that when surgery is being performed, that the hospital, the facility has the capability to have real-time factor testing so that we can prevent any unnecessary complications. And then just by the fact that there's chronic inflammation in those joints, that increases the risk for cardiovascular disease. All right, today's reminder again, we're not getting older, we're just getting more awesome. All right, this is probably one of the more serious things to discuss, and that is the situation of brain bleeds. A hemorrhage or uncontrolled bleeding of any kind is the third leading cause of death in hemophilia. And brain bleeds account for 30 to 50% of those hemorrhagic deaths. There is an increased risk of a brain bleed if an inhibitor is present, and there is an increased risk if high blood pressure is present. So following a brain bleed, complications and concerns would be reduced cognitive function, things like abstract thinking, attention span, critical thinking, decision making, ability to focus, language, either communicating verbally or understanding spoken language, logic and reasoning, and memory. And we would also be concerned about some reduced physical function, trouble walking, trouble using your hands, speech, leading to an overall reduced quality of life and worst case scenario, death. So brain bleeds are one of the things that we really worry about, especially as we get older and our balance is not so good and we have falls. All right, so what about our kidneys? What should we be thinking about as we age with a bleeding disorder and kidneys? So it's important to know that kidney disease in a non-bleeding disorders patient presents concern for excessive bleeding. In the setting of renal disease, there is a condition called thrombocytopenia that develops. And thrombocytopenia means low platelets. So even if you don't have a bleeding disorder, the fact that you have low platelets puts you at risk for bleeding, because we know those platelets are the first thing that shows up to try to stop a bleed. So if you have low platelets in addition to a factor deficiency, that just sets up an additional situation for excessive bleeding. So for severe kidney disease, we begin to be concerned about dialysis. How does that affect the body? And dialysis can interfere with the clotting cascade, which in your case would not be ideal, but it may be necessary. And then we have to, balance the need for the dialysis versus what we need to prevent your bleeding. One thing that is usually required for dialysis is something called an AV fistula. And an AV fistula is when they go in surgically, usually in the arm, sometimes in the leg, and they sew together an artery and a vein. So that makes me concerned right away that we're sewing together an artery and a vein. So that's something that would need to be done in a very, very specialized setting. But with successful dialysis, there is improvement in that thrombocytopenia that is associated with the kidney failure. So always good news and a little bit of bad news. All right. And let's talk about cancer. So the overall risk to our bleeding disorders population is similar. There's not really any data that says our bleeding disorders patients are more prone to cancer than the general population, with the exception of the two things we talked about earlier, issues related to undertreated, advanced, or untreated HIV and hepatitis C. But some complications that we would need to look at and consider. Many cancer treatments result in the thrombocytopenia or low platelets. And then as surgeries are required for cancer treatment, we do begin to be concerned about that as well, knowing that our patients will need additional factor support to get them through the surgery and the recovery. So obesity. There's a similar prevalence in the general population and our bleeding disorders population, 31%. But concerns for obesity increase when we talk about it happening in conjunction with hypertension, with type 2 diabetes, with stroke, coronary artery disease, osteoporosis, clinical depression, reduced range of motion in your joints, and increased chronic pain. And obesity is calculated by your body mass index. So here's the calculation. If you're interested, you don't have to share your answers because I won't share mine. But you take your weight in pounds and your height in inches. So you take your weight in pounds divided by your height in inches, divided by your height in inches again, times 703. So for example, we have a patient who weighs 150 pounds and is 66 inches tall. So 150 divided by 66, divided by 66 again, times 703 is 24.2. So 24.2 is actually considered a normal BMI. Overweight would be 25 to 29.9, and obesity would be a BMI of greater than 30. All right, neurological and physiological issues. What in the world does that mean? So, common issues in the general population that would also apply to our bleeding disorders population, because these are solely related to age. Neuropathy, which can be numbness and tingling in your hands and your feet. Alzheimer's, Parkinson's disease, myopathy, which is muscle weakness, ALS, which is a progressive disease with deterioration of muscle function, stroke, myasthenia gravis, which is an autoimmune neuromuscular disease. And then some psychological issues, decreased social contact as we get older. Friends and family die, and sometimes we withdraw into our houses, although we've been withdrawn into our houses for over a year. Changes in roles and tasks that people can do can also make you feel like you have less to contribute. And managing your leisure time, which sounds like an oxymoron, but if you don't have hobbies or you don't have outlets, you can have too much free time on your hands. And then depression. And again, older patients in the bleeding disorders community, there's not a huge difference or any data that supports you're more prone to these issues than anyone else. But there are some issues because of the joint damage, muscle issues that have been from previous bleeds. Hemophilia patients do report decreased physical function as they age. Things like dressing, managing the small buttons, the zippers, the latches, bathing, shopping, cooking, and other activities of daily living. And we know that increased or even just chronic pain can lead to a lower health-related quality of life. Depression in our bleeding disorders community, that can be related to a multitude of things like chronic pain or just living with a chronic illness, such as your bleeding disorder, which may also be in conjunction with HIV, hepatitis C, and other health issues. And as far as cognitive function is concerned, there's no evidence to support, again, that there's an increased risk of Alzheimer's or dementia as compared to the general population. But there are some complications and concerns to worry about. Your factor treatment schedule, it can become more difficult to perform, whether it's IV or subcutaneous injection. When we talk about those little vials, and the syringes with the little markings on them, those all present challenges for us to think about. You may can't remember if you're not writing it down. Did I dose 1 day ago? Did I dose 2 days ago? Is it time for me to dose again? And then the issue of falls comes into play based on some of the neurological issues that can happen just as a result of aging. All right, inhibitor development. So in our bleeding disorders population, inhibitor development risk does increase with age. There was a UK study, and for hemophilia B at age 50, there was a 30% increase of inhibitor development. And at age 75, there was a 36% increase risk. But for hemophilia B, for all ages, and this is true always, the increase is 8% for hemophilia B. Hemophilia B is not as prone overall as development of inhibitors in hemophilia A. Inhibitors usually develop at a young age in severe hemophilia. And an inhibitor is when your body begins to see your infused factor as a foreign substance, and your immune system creates antibodies to get rid of the factor that's infused. So no matter how much factor you pour in, if you have an inhibitor, your body just eats it up and gets rid of it. So it usually occurs in the first 20 to 50 days of product exposure. So if you are a severe hemophilia and you started prophylaxis early, those first 20 to 50 days happened when you were very young. But the reason we are concerned about this as our patients age, especially with mild disease, that a major surgery may be your first 20 to 50 exposure days of factor. And that may be when we see an inhibitor develop, because your body has never seen that much factor before. So that is something that we think about, and we keep an eye out for and test our patients for. So other challenges, long-term needs for venous access. So, with the exception of Hemlibra, everything is still intravenous. So we talked about this in the neurological section, and your dexterity, the ability to hold small objects, hold the vial, put the mixing device on, twisting the device, and putting the diluent in, drawing that out, all those things that take very fine motor skills. So I think our manufacturers down the road are going to have to look at, for our older patients, how we can make that easier for them. We also worry about fragile skin, doing intravenous infusions 2 to 3 times a week, or even more often if there's a bleed. We worry about skin tears, and we worry about skin infections with that, continual puncture through the skin. Dehydration becomes a problem, and we all know when we're dehydrated, it's harder to obtain that venous access. And as we get older, and perhaps we deal with urinary incontinence, we may not drink as much fluid as we should, which is going to make venous access more difficult. And then our eyesight changes. Again, we talked about this a little bit earlier, looking, at the little lines on the syringe, or looking at the small print on the vial and on the boxes. So again, there are some issues that we're going to need to address. So I'm one of those people who are always saying, where are my glasses? Where are my glasses? I just had them a minute ago. Where are my glasses? So I hope I'm not the only person in that situation. But I did want to share a big win with you. there is something called the Hemophilia Snf Access Act. And this has already been passed into law, but it does go into effect October of this year. And it is a provision that improves access to skilled nursing facilities for Medicare beneficiaries with bleeding disorders. This might not be something you've ever encountered or ever known about, but for years, well, up until now, until this law takes effect, anytime we had a patient who had to go from surgery to a rehab facility, the facility would not infuse their factor. In fact, they wouldn't even keep it in stock because of the cost. So the patient would have to be transported from the rehab facility to the infusion center to get their factor infusion and then back to rehab. So it has not been an ideal situation forever. And so now for our Medicare beneficiaries, that is going to no longer be a hurdle. So that is a huge win. And we have so many people to thank for that. Our national organizations, NHF, World Federation of Hemophilia, and all of the advocates, patient advocates such as yourselves who go to the Capitol Days and Advocacy Days to help our lawmakers understand what our bleeding disorders community needs. So in summary, with a very few exceptions, such as high risk for hypertension, arthropathy from hemarthrosis, some kidney disease concerns, and some liver disease concerns, overall, aging affects the bleeding disorders community in much the same way as the general population. The complications and considerations come into concern when interventions are needed. But the good news is that we are aging, you are aging just like everyone else, and so we'll tackle the challenges that come our way together. And that's why your Hemophilia Treatment Center team is here and why we need to be a critical part of your lifelong care. So with that, I will conclude and open the floor to any questions.
Pam?
You went through the obesity chart kind of quickly. Is it possible for you to back up to that chart calculation for a second?
Oh, absolutely. Yes, sir. So you take your height in inches and then divide it by, you take your weight in pounds. So say you're 150 pounds and 66 inches tall. So you do 150 divided by 66 and then divided by 66 again, times 703.
And what was the scale?
The scale is, let me see, it's 25 to 29 is overweight, and anything above 30 is obese.
Thank you.
And I will not ask you to share your results.
Pam?
Yes.
This is Beth and Glenn. And let's look at the wonderful news that in October of this year, our people with bleeding disorders can be at skilled nursing or rehab centers. That is wonderful news. Can you hear me okay?
I can, yes.
Pam, can you hear me?
Yes, ma'am, I can.
Okay. Okay. Were you able to hear my question?
No, I was not. Can you?
I'll use chat because our signal from here is weak. It's not your problem, it's ours. So.
And Beth, we heard enough to know about that you were mentioning about the Skilled Nursing Facility Act, but couldn't hear the actual question. We heard
Yes,
the lead up to the question.
it's, will infusion nurses be able to go to somewhere like Sardis Oaks or other facilities to do infusions?
Well, that's been one of the other problems, that
Oh, yeah.
the facilities would not allow the home health nurses to come in and give the infusion. So that made it necessary to transport the patient from one place to another to get the infusion. So hopefully this is going to change a lot of that.
This is something we have dealt with a lot.
Mhm.
In fact, just in the last since January, February, March, Glenn was at UNC Chapel Hill hospitalized for 41 days.
Mm.
We could not find a placement for him here in Charlotte because no one would take him. They didn't want to stock factor, and they did not have team members who could do his infusion. So we are thrilled. We hope he never has this need, but should he, we're delighted. Maybe the fact that that this is in place, that's going to help, because we have a favorite rehab center, and that's Sardis Oaks.
Mhm.
And it's very close to home, and their care for him was wonderful. But now that he's on regular infusions, they, stand a little standoffish with us. But fortunately, he was able to have rehab at Chapel Hill.
Oh,
So
good,
this
good.
is great news. We look forward to seeing how this will all be put into action, Pam.
Yes, we are all looking forward to how this actually works in action, as you say. Although it is a law, and when it becomes effective, could be a little bit of a slow ramp up because it's going to be a different world for our rehab facilities, but a big win for our patients. Thank you for your question.
Question.
Sure.
You cited bleeding as the third leading cause of death among hemophiliacs. What are the first two?
The first two are more related to what happens in the general population, heart attacks and strokes.
Pam, I just wanted to compliment your presentation. It was excellent, excellent examples. The way you reviewed it was extremely professional.
Thank you.
A lot of enlightening statistics in that. And the scary part for me is I'm all over your charts. But it was very informative and very entertaining. So thank you.
Well, thank you, Rick. I appreciate that. I certainly didn't want us to come away feeling all doom and gloom, especially late on a Saturday afternoon. But aging is happening to all of us, and we have to think about it and how that's going to affect the health of our bleeding disorders patients.
Yeah, that was a great review.
Thank you.
Are there any other questions?
Did anyone have time to Google when the first Hemophilia Treatment Center?
I tried, but couldn't find it, but it did mention 75, like you said, 1975.
I think there were several established all at the same time because it was a CDC effort.
Yeah,
I'm on
Charlene,
Child
do
Health.
you know when the first Hemophilia Treatment Center?
I agree with Charles. I know that UCLA also implemented it back in 1975. And that was our first HTC there in California, I believe.
Okay. Yeah.
UNC was pretty close.
That'll be a good trivia question for an HNC event.
Yeah.
Those of us who are here will know the answer.
Yes. Any other questions before we move back to the main room?
Well,
Well,
thank you guys all for being here. I really do appreciate your time and attention, your questions and compliments. You know, it's a real pleasure to be here with you this afternoon.
And Pamela, thank you so much for coming in and doing this session. I know it wasn't originally on your radar to lead this session, but I stayed mostly in this session, and I have to say you did a really fantastic job. And this is something people have been asking Hemophilia North Carolina to do a session on for a while now. And so I really appreciate the effort that you put in and the amount of detail and wide range of topics that you hit. Thank you.
Well, you're welcome. Trust me, I learned a lot too, and we have a lot more to learn.
Well, and we also just learned that Wake Forest received funding as an HTC in 1976, as well as UNC. Thank you, Anita.
Thanks, Anita.
So we can add on to our questions. That'll be the bonus round question.
There you go. I love it.
Thank you, Miss
Fantastic.
Pamela.
Thank you
for
guys. Have a
everything.
great rest of your day.
You
Thank
too.
you.
Thank
So
you.
we have
Bye.
one more
Thank you.
session, so y'all can click the leave room blue button on the bottom and head back to the main room, and we're going to learn about genetics.